Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
All right, well, welcome back. We have a couple of panelists on this episode. We are talking about affiliations and specifically in a post-COVID environment. And joining us today, we have Mark Reiboldt, Aimee Greeter, and Richard Romero, all senior team members at Coker. This is one of the topics that we have been tracking very closely throughout the whole COVID-19 pandemic, the quarantine, the resulting effects on healthcare providers and volume, et cetera. And very clearly, this is going to be something we believe that is going to have a very significant effect as we continue to emerge from this very unique event in the world and in our industry. And so we thought it'd be helpful to just come on and talk about some of the things that we've been tracking, looking at, and then some of the other topics and issues that will continue to come up and have more dialogue as things unfold. Coker released a white paper recently covering this topic at a very broad level, but kind of all-encompassing perspective on some of the things we're looking at and expecting in this particular area. So that's really what we're going to talk about today. So you can read that white paper and follow along. I think as a starting point, and I'll probably have Max tee us up here, but give us kind of an overview. I don't think we have to spend that much time talking about response to COVID-19, but how COVID-19 and this pandemic event is going to really tie into the idea of an increase in affiliations amongst healthcare provider organizations.
Thanks for everyone's time today. We're looking forward to a nice discussion about a very relevant topic. So I guess if we mark somewhere in the early to mid part of March forward, we've all experienced unprecedented work, life experiences, and clearly we're still undergoing adjustments as it relates to that. So the healthcare industry, not surprisingly, has probably been the most affected when you put it all in balance with the clinical side as well as obviously the business side, which we're going to focus more so on today, of course. As it relates to what we've seen and have observed, the initial pandemic reaction, I think, was incredibly appropriate among healthcare providers, hospitals, physicians, and that was to first and foremost take care of their patients, take care of the health of the country. So that should go without saying, but be remiss if I didn't say it, I think. So where does that leave us, and where is that has that left the healthcare providers in this country? Well, first, I don't think there's probably any of them, with very few exceptions, that have experienced a positive financial outcome as a result of the work that they've had to do and the changes they've had to make. So virtually every healthcare provider, physicians, hospitals, doesn't matter, are in the midst of rebounding or somehow trying to get their collective lives back together as it relates to what they've been doing over the last 90 days or so now. So that's something that I think we all have to keep in mind, remember, and respect. For example, I've been working with a large gastroenterology group in another city outside of where we're based in Atlanta, and they have 3 endoscopy centers, very vibrant, and it's truly the, quote, GI group in the community. They closed their GI center completely somewhere around the end of March and stayed closed, did absolutely no work, no revenue for the entire month of April. And only into the actually mid part of May, I believe, did they start to reopen and start to do colonoscopies, et cetera. So they actually had no revenue whatsoever. Now they were still engaged in clinic and had a little bit of patient contact in that regard, but clearly not as much as normal. So that's just one example of thousands, hundreds of thousands throughout this country. Hospitals have experienced the same decline. We have a client, a large health system with multiple hospitals, and they essentially stopped doing all elective surgeries in contemplation of filling up their hospital with COVID-19 patients. And so their revenues are, since they rely so heavily on elective surgeries, as many do, we're essentially devoid of any significant dollars either. So that's what we're dealing with here, is coming off of a truly unprecedented crisis. So how and what's next? Well, the premise that everything's going to resume back to normal, if you want to call normal pre-pandemic, is naive and totally incorrect. I don't know that we're ever going to quite return to that. I do believe that over a fairly long period of time, months, not years, but certainly over an extended number of months, that we're going to slowly creep back to some semblance of normal. And so when we get into more of the discussion today relative to transactions, alignment, affiliations, things like that, we'll talk a little bit more about what that might mean. But I think as of right now, to kick this off, this discussion today, we're not talking about a return to normal. I do think there'll be a lot of transactional work between healthcare providers, and we'll get into that, and that'll relate to valuation work that Richard will talk about. It'll relate to some of the strategic things that Aimee will touch on. Hold on to your safety belts or tighten them a little bit, because I think we're all going to be in for a different ride than we've ever had before when it relates to post-pandemic structures in healthcare in general in this country. So, Mark, I'll stop there at this point, because I know there's a lot of other really good input that we're going to have, but I think that hopefully lays the groundwork for what we're going to talk about today.
Yeah, no, I think that sums it up well. I think impetus for us now talking about this is thinking ahead, thinking in the future. And we know, I mean, there are a number of things, and we outlined these in the white paper and have talked about them elsewhere as well. But the situation that you described with the decreasing volumes and much lower utilization, is going to have a trickle effect. And so it's not something we know this whole situation is not going to turn around overnight. And just in the same way, the economics won't turn around overnight either. I mean, it'll take some time, I guess is the point. And we are going to talk about that. We are going to talk about some of the economic considerations and kind of even getting into some of the different affiliations that we can start thinking about and looking ahead to, as far as what's probably most likely. Before we do that, though, Aimee, I want to throw it over to you and focus on something that's kind of it's often overlooked, even pre all of this stuff, in a lot of alignments, affiliations, mergers, acquisitions, but the whole strategic, non-economic perspective, specifically as it relates to leadership and how that's going to potentially play out here as we think about a new wave of alignment transactions post-COVID. Any thoughts there?
Yeah, that's a topic that I'm passionate about, so I've got plenty to say there. And I think what we need to think about is really what is important with respect to leadership during a crisis, and then how does that leadership look different after a crisis? So in my mind, there are at least 3 things that you need to be very mindful of during a crisis. I think the first one is really creating a common goal, creating something that can be a rallying cry for people. During COVID, we have an organization that created a common goal that was, we are not going to allow any of our caregivers, that is, all of the providers within our organization, clinical, otherwise, to perish as a result of contracting COVID at work. And that became a huge rallying cry for this health system. They wanted to make sure that they were doing everything they could to keep their employees throughout the organization safe. Not only that they were introducing institutional controls to make that happen, but that there was this sense of shared purpose where people would look out for each other. If somebody needed PPE, there was always somebody that was willing to either give up theirs or find some, do something so that we were keeping our people safe. And what this organization did is that they created that goal and widely publicized it. So they cited it in all of their communications, their written, their verbal. They kept it on their intranet home screen so that it flashed through, as people had it on their computers. They used it in their daily huddles that they were using as a communication vehicle. And so it became very clear that everyone was united about this common goal. And I think that was a really good opportunity that leadership took. And I think it created a single message that everyone could think about, focus on. When we all get all these messages about COVID, it's easy to get lost in so many different considerations. But having a singular goal, I think, is really important to do during a crisis. I think the second thing I would say is leaders need to be over-communicative, not just communicative, but over-communicative during a crisis. Certainly, many organizations feel like communication is subpar, and there is no better opportunity to increase your communication than during a crisis. Different client than we have is a level 1 trauma center. It has approximately 550 beds, more than 850 physicians on their staff. And what they decided to do is they created a daily huddle at noon. It lasted exactly 15 minutes, and their CEO ran it both in person and it was live streamed so that everybody could see it. And practically everything in the organization stopped for those 15 minutes. Meeting times were changed so that from noon to 12:15, it was protected. Breaks were scheduled to allow maximal participation from people throughout the hospital. And that daily huddle became a communication tool for everyone. Now, it wasn't bi-directional, meaning there was only communication that was delivered. There wasn't communication that was received back or solicited feedback from constituents. But that was also helpful in terms of keeping it to 15 minutes. But feedback was solicited in other forums. But that 15 minutes became a way in which everyone heard the same daily update from the same person who delivered it. The theme was, kept consistent. The agenda was kept consistent. For 15 minutes, everybody got that communication. So I would challenge people when they think about, how do we lead? How do we communicate? Start with 15 minutes a day. And I say that somewhat tongue in cheek, and I'm laughing here. You can't see my face, but we all recognize that 15 minutes takes another hour probably of preparation from various people that are developing information, that are consolidating data, et cetera. But when you think about communication during a crisis, I challenge you to think of it as 15 minutes in which you're going to create that huddle every day. And then the third consideration I would give you with respect to leadership during a crisis would be to create a dedicated, diverse team to lead you through this process. If you've ever heard me speak or you've ever read anything I've written, you likely know that I have a strong stance in support of heterogeneous teams. The literature is very clear that heterogeneous teams create the best operating results. And I would say that during times of crisis, there may be no higher stakes. And so to make it concrete, what I would say is that the dedicated, diverse team that you choose to help you lead during a crisis needs to have at least 6 people. And those 6 people would be a leader, number one, by their title, likely a C-suite executive, whether it's your CEO or your COO. Second, you're going to need clinical leads. And I would make sure that you have both physician and nursing functions represented in those leads. Number 3, I think you're going to need a member of the finance team, someone who can report both on the impacts financially of what's being experienced, as well as help with the projections of certain activities, certain things that are being contemplated as an action. Number 4, I would make sure that you have a member of your communications team. And if you're an organization that isn't that big, who doesn't have a quote communications team, it can be whoever functions in that role, but you're going to need to keep that communication team looped in. You're going to want their feedback. And then lastly, you're going to want an advocate for your staff, whether that's someone from your human resources department or your EAP program, whoever it is, you're going to want that staff member. So again, your leader by title, both a physician and a nursing function, clinical lead, a member of the finance team, a member of the communications team, and then an advocate for staff have to be part of that diverse team. I will say there are probably lots of other things that leaders can do during a crisis, but I think those are three critical ones: creating that common goal, over communicating, and then using a team that's diversely dedicated to leading throughout that crisis. Now, if you're interested in thinking about what leadership needs to look like after the crisis, I think we also need to think about two very important things. I would first say that one of the most important things you can do, although this sounds aggressive, is to keep your hand on the thermometer after the crisis passes. And what that means is that it's very easy for people to get spun up during a crisis, right? Your adrenaline pumps, you're ready to do whatever it takes. Most people go into that fight mode where we need to rally together. But I think if we take the opportunity when the crisis passes to let that completely subside so that there's no more urgency in the organization, I think you're going to find that the temperature is too low and that people are going to get complacent. They're going to be unwilling to think outside of the box. They may be unwilling to make difficult decisions. And so you need to keep the thermometer turned up so that it's in a sweet spot, not too low where people aren't willing to take actions, but not too high in that people are unwilling to take risks or they're unwilling to make decisions that may be seen as unpopular. You don't want people to get into panic mode, but you want to keep your hand on the thermometer so that you can keep things kind of ratcheted up so that there's still a feeling of urgency. So there's a popular case study that we see with respect to healthcare in which an organization in the Northeast has a new CEO that comes in. And he steps in at a time in which the organization is in an operational and a financial crisis. The health system is the product of a merger of two different health systems, two different hospitals. Their integration from a cultural perspective is tepid at best. There's really a misalignment of cultures that hasn't been brought to the forefront. And so you're having this clash of cultures. There's also some very real financial challenges. The organization is on the precipice of being on the chopping block to be acquired by a for-profit entity. And so the CEO comes in and does three things that I think effectively illustrate the ability to keep the hand on the thermometer, the thermostat. And that is, first, he sends out a public memo that specifically and vividly calls out the challenges the organization is facing. Number one, there are ongoing financial hardships. They're in the red. They are not operating in the black. We can't continue to be sustainable in the red. We are going to have to lay off employees as a result of our financial hardships, and we may have to sell. The memo used verbiage like, this is our last chance. We need to do this together, creates this sense of urgency. And so that public memo, I think, became a very real increase in the dial to be able to turn that thermostat up, to be able to say, we are not out of the woods. We all need to come together and look at things. The second thing that happens is that CEO makes a pretty robust call for continued accountability in terms of performance. So he says the organization is going to begin publishing quarterly reports on medical errors. And so our performance is going to be available not only for us, but publicly, so people can see what we're doing. And we're going to continue to focus on reducing medical errors over the next 4 years to where we bring them down to appropriate or non-existent levels. And these two things, first, the setting out of challenges specifically and vividly in that memo, and then second, that call for accountability, are really effective in turning around the organization. But what you can imagine is that, again, here, while not an ongoing crisis, it's an acute crisis. It's an acute crisis that becomes chronic. And so people start to tire. They don't keep their hand on the thermostat as well. And so a few years later, things start to falter again. And so what happens is that the organization is facing 3 years later, a $20 million projected annual loss. And so this same CEO comes in and has an employee meeting to discuss layoffs. And what became clear is that the layoffs were going to impact low wage employees disproportionately. So those are people in our FANs, our food nutrition or our environmental services divisions layer the most. And so what happens is that the CEO proposes somewhat tacitly protecting the lower end jobs by reducing the salary of people who make more, the people that were in the room as they're having this conversation about what to do. And so what happens, despite the fact that this could be a large impact, at least to a large number of people, hit their pocketbooks, the idea was met with applause. And so because we kept this sense of urgency that our people are going to be subject to layoffs, the people that we need potentially the most, there was this rallying cry. And so I think if we think about keeping our hand on that thermometer, on that thermostat, if we can think about how we keep that pressure going forward, I think it will be important in creating the best versions of organizations. I don't know that we need to, again, create panic amongst people, especially when people are going to need some breathing room. Right after COVID, we're going to need to let our people have an opportunity to recharge. But letting people know that while we may be out of that acute stage of the crisis, the reality is that challenges are going to continue to affront us. And we're going to need to continue to think about how we make decisions in an environment that's going to be wrought with challenges going forward. But the last thing I would say with respect to leadership after a crisis is making sure that you evaluate the changes that have been made and decide what stays and what goes. So I saw a telehealth survey that was conducted in May of 2020 that indicated that 63% of physicians were using telehealth at present, likely as a result of the COVID crisis, compared to 20% adoption before COVID. A separate survey indicated that of the current users, 60% of them intend to continue to use telehealth into the future. And so what we see is this massive influx, this massive utilization of telehealth that wasn't there before. And yet I've also done some research that indicates 35% of the American population does not have broadband internet access. And so more than a third of our Americans don't have the ability technologically to communicate via live or video-based telehealth services that are necessary using that sort of broadband internet. And so what are we going to do to not only see how we can improve upon the things that we have, but also decide what we need to do in the future differently? Asynchronous communication has often been cited in recent weeks in terms of how we create a telehealth model that's sustainable. So having things that level the playing field for people that don't have what we would consider to be more advanced technologies. Asynchronous communication like texting, where we can have some input and then asynchronously we receive feedback back. Maybe that's what we need to think about, is that asynchronous or dyssynchronous approach to telehealth. If we haven't been doing that now, if we've been really focusing on reaching the people who have those live or video-based technologies, maybe we think about encouraging telehealth that can reach more people, have a broader audience. There was a bill that was introduced just yesterday, actually, that examines the usage and benefit of telehealth, with the whole intent being that we're going to look at what can be the permanent solutions to telehealth payment. So as we all know, there's been authorizations for temporary measures that provide remuneration reimbursement for telehealth. But bills like this need to, in my opinion, be looking at what are the long-term permanent solutions here. So let's do that. Let's do those analyses on telehealth. Let's look at its usage. Let's look at its benefit, but let's not waste our time. Let's go quickly so that we can address some of those temporary solutions so that, again, as leaders, we can evaluate the changes that have been made. We can decide what stays and goes. And we can do that knowing what the real economic implications of that are going to be. So, Mark, that may be more than you ever wanted to know about leadership throughout and after a crisis. But I think that there are some real things that leaders can do now and into the future to really make sure that we're acting appropriately during this crisis and using some of our best practices afterwards.
No, I think that's great. And I appreciate you running through that, because while there's a lot there, I think this is something that you made this point multiple times. It's not going away. So these concepts are going to apply, and they are going to be relevant far long after the initial crisis subsides. And I think we've realized that this is definitely we're in kind of marathon mode and not a sprint short distance race. And I think that tees up kind of the prospect of what we're really talking about on affiliations and transactions, because now more than ever, perhaps, there are a lot of groups out there that are thinking about what are the best long-term options, not just in light of COVID-19, not just in light of the resulting decreases and economic challenges that have come, but truly thinking around the curve as best as we can. And so if there are a lot of groups out there that doing some sort of deal may be an option, or maybe it's not an option now, it's on the horizon. Well, now maybe that horizon has shortened a little bit, or groups out there that never thought they would do it, but now it's an option. So, and maybe I'll throw this back to Max and just kind of, briefly walk us through as we think about looking ahead, post-COVID, alignment options, and some of the perspectives that we think that will be front of mind for both hospitals and physicians and others as we think about the different actors involved here.
Yeah, thank you, Mark. And thanks, Aimee, for that great overview on leadership. I learned a lot just listening to you myself. So what to do and how many deals are going to get done and who's going to take the assumption of the front of the line and who isn't in terms of getting deals done. In our white paper that we're basing this podcast upon, we tried to break it down into somewhat of a component type review where we looked at physician to physician, potentially more mergers and aggregation of groups, if you will. We looked at the concept of clinically integrated organizations and how that might be another form that would take heightened attractiveness for physicians and hospitals. Needless to say, we looked a lot at hospitals and where they fit in, and we'll touch on that briefly. And then last but not least, we looked at the for-profit, but more so focused on the private equity side of transactional work between different providers. I personally believe that if we looked at the first one, group mergers and groups coming together and aggregating, I think there'll continue to be some of that. It's a challenge before the pandemic to merge groups for reasons I probably don't need to go into. I think if anything, those challenges have become heightened with the loss of revenue and lack of economic performance, if you will, in 2020. I think that the capital to fund mergers of groups will not only be less, but the interest will be commensurate with that. So I don't think there'll be as much of it. Now, obviously, I could easily be wrong, and I'm not saying there will be no group mergers, but I truly believe that we'll see fewer and fewer of those for the reasons I outlined. As far as clinically integrated organizations, we've already seen some interest with some individuals that have contacted us at this juncture. to kind of rejuvenate some discussions along those lines. I had a call yesterday with a party that was literally focused in on that sort of thing. And so I do believe that we'll see some of that. If you ask me, well, what about value-based reimbursement, quality payments, as opposed to fee-for-service, which largely may be driven by those types of forms of affiliation, the clinically integrated entities? Probably answer the same I would have even before the pandemic, that it's slowly coming along, but the focus has been so much on, and now is just on getting back up to where we were, trying to undo the losses, if you will, or make up for them, that I'm not sure that there'll be, again, the capital that will be needed to pull those types of consortiums together. So where does that leave us? What will physicians that are not aligned with anyone, hospital, private equity, will they, or let's say the ones that are, will they gravitate to one or the other? Will they try to stay private? Will they go private? Interestingly enough, if they feel because they were put on furlough or perhaps their compensation was reduced during the pandemic, will that leave a sour taste for the future? I think those will all be some possibilities. I think for the most part, though, we'll see more and more existing aligned groups, employment, PSAs, et cetera, that will continue and will try to even re-up and enhance their relationship with hospitals in this instance. I also believe that there'll be more and more private physicians groups that of all specialties that will look toward some form of affiliation. And again, when you boil it down, it will be, I think, mostly and somewhat oversimplified, but mostly directed toward private equity and hospitals. So where does that leave us in terms of the types of deals? Well, I think hospitals need to keep an open mind as it relates to how they structure a deal. Professional services agreements have worked. By and large, they're appreciated, they're legal, they're very compliant oriented, they're liked by most physicians, and quite frankly, many hospitals really prefer PSAs as opposed to employment. With that said, employment will clearly still be in vogue, and there'll be a lot of new deals that will, and deals that'll be re-upped for the second and third generations as such, that will largely comprise of employment. I do want to take a slight sidebar discussion track, though, and I do believe that more and more physician groups will be looking to hospitals to do joint ventures and joint equity deals. And that could be real estate, it could be ancillary services, you name it. Anything, obviously, we've got to stay within the white lines of legality and structure them. But I do believe that there'll be more of that entrepreneurial thought. And why will that be the case? I'm working on a presentation for another Association of Virtual presentation about how hospitals are going to respond to private equity. And I think one of the ways they're going to respond to private equity is being more open to doing equity deals with groups vis-a-vis ancillary services, real estate, et cetera. And so I think we're going to see more of that, where physicians are going to say, hey, you know, within a private equity group, we can have a piece of the ancillary NL action, ownership, in other words, and we'd like to have that with hospitals. So I think we'll see that. And then last but not least, private equity. Where does that leave us? I think some private equity groups are reeling from the pandemic. They obviously have not met their numbers in 2020, and they're not going to through no fault of anyone. So whether or not they have the capital and the capacity to do new deals, there may be a little bit of a lull for 6 months or so, maybe even the rest of this year. On the other hand, when you look at a larger private equity group, I was talking to one yesterday that is invested in several industries, not just healthcare. And in listening to some of the principals within that private equity group, it was clear that they're focusing on healthcare because healthcare is probably the least risky, if you want to put it that way, and will rebound, at least in their view, quicker than some of the other industries with which they're invested and with whom they're invested in. So that's an interesting twist that may actually allow for private equity to invest their capital, and I still believe they have plenty of it, to tilt more towards healthcare related investments. I do think private equity deals, it's interesting. And I want Richard to comment on this as it relates to the valuation work soon, but we use everyone knows the metric that we use for valuing at times, and it's EBITDA, earnings before income taxes, depreciation, and amortization. Well, we've added a C to the end of that. It's EBITDA C, which the C standing for COVID. And there are some lines of thinking about, the valuations tied to EBITDA will be lower. The multiples may be lower because of the effect of COVID. And we'll see if that puts a damper on some of the private equity deals and even the interest that would lie in doing private equity deals. Bottom line, to try to answer your question and move on, Mark, I would say that the transactional activity on an overall basis within all of those arenas that we tried to touch on within our white paper will be active, will be vibrant, and indeed there'll be a lot of deals getting done, with the possible exception, in my view, and I could easily be wrong, of fewer mergers of groups because of the lack of capital that it requires typically to pull off a merger. You could have some what we call legal only mergers where there's very little operational consolidation, and they basically just come together as a single provider, not much else. But other than that, I think we'll focus more on hospitals and private equity deals with equity ownership as well. So I hope that helped answer the question.
Yeah, no, I think that framed it very well. And I think you teed it up well for us to skip ahead to the discussion around economics, because I know this is something that's on the front of mind of many. I mean, you got some of the largest health systems in the country that are reporting hundreds of millions of dollars up to billions of dollars, multiple billions of dollars in losses or decreased revenue as a result of everything that's happened thus far this year. And as you said, I think, we're not out of it yet. So it's going to continue to inject some sort of stress into the market. So, Richard, I'd love for you to chime in here as we talk about kind of the economics. I mean, I think there are so many different angles here. Again, from Coker's standpoint, our general stance on, we have multiple points as it relates to our general perspective on this topic, but, the economic improvement is not going to come back overnight. It's going to take time. You have to think about the impact on physician compensation. You have to think about the impact on volume and utilization. This whole even new kind of term of EBITDA C, and looking at value, earnings value. And then you think about, you can get really technical here, and we don't have to do that now, but we are going to have additional content specifically talking about valuations post-COVID. And that's a whole other rabbit hole that we can go into as far as the different methodologies and how we're going to have to make adjustments. So maybe just frame for us, if you will, Richard, the general perspective on what we think, looking at it today, when we think about transactions and alignment scenarios and affiliations, some of the key things to keep in mind as it relates to valuation.
Thanks, Mark. And I think some key points to think about anytime we talk about valuation is, I always like to provide a framework which I call the universal equation for valuation, and that is value equals benefit divided by risk. And so if we use that to frame our discussion, we're really looking at a fundamental shift and a fundamental change in current or go forward operations compared to historical operations. And not to dwell in entirety on telemedicine, but we now have a fundamental shift in modality, as Aimee was saying, and the 60% number is one I hear from a number of surveys, including our own that we did related to new use. So if we think about that, we've got a change in modality, and the old axiom in healthcare was that all healthcare is local. Well, add telehealth or telemedicine, and that's now expanded beyond historical borders. But if we look at the economics of what we're dealing with, is our benefit is essentially a revenue stream times a volume in some level or some measure. That can be difficult to determine on a go-forward basis. Although we're seeing signs that historical case volumes are increasing, going to get back to perhaps historical levels, that may or may not occur. Even if it does, given the economic downturn that we have, are the reimbursement levels, are we going to have the same level of insurance rates for those patients? So when we look at the benefit side, the rate and the volume, we need to make sure that we compare that to historicals. The other fundamental piece is, as Aimee was talking about in terms of the case study, is what is the level of staffing and what are the level of resources that are necessary to generate those revenue levels going forward. And so I think there's a fundamental opportunity to look, and as Aimee has quoted, what stays and what goes. So as we're looking at this, as we compare back to historical measures, benchmarks, whether that be on valuation or in compensation, this is an opportunity to say, what should we do going forward? It's almost an opportunity to revamp what we've historically done. And as we look at that, it still holds true in terms of value, though, is what is the expected benefit and what is the risk associated with that? We've got different dynamics. We need to look at what revenues, what resources. Staffing is going to be huge. And as we have entities that are entering into agreements, being able to assess what your risks are for those factors and being able to effectively communicate those to both parties and to your valuators so that they can effectively price that is going to be important with regard to valuations. I think, as Max was suggesting, the EBITDA C or COVID, I think clearly to suggest that there's going to be no change would be a little naive or perhaps significantly naive. So I think what we want to do is make sure that we're looking at historically, what have we done? What are those changes? But value is a forward-looking concept. So from that date, what do we expect to happen on a go-forward basis? If we kind of transition a little bit, looking at that's more on the valuation of entity side, even as we go to more of a compensation side and we look at various specialties, we also have to think that across the board, everything won't have a declination to it. We learned as in the American lexicon, we heard ventilators, masks, PPE, and what our new normal is going to be. I think if we look at some of the specialties, take critical care. I mean, they manage ventilators on a regular basis. Think about as we were confined to our homes, the increase in demand for behavioral health, which we saw significantly. So there are actually some aspects of healthcare that had, quite frankly, a boom as a result of COVID. Overall, in some of the traditional specialties, we saw significant cuts in revenue. We had the decline in surgical procedures. Volumes are down, and hospitals were basically hoarding and keeping cash. So I think in terms of being very strategic about the future opportunities, where are they going to get the return? And even as on the affiliation side, there's going to be a close analysis about that concept of risk, right? When we saw, especially in the fee-for-service market, we saw a mass wave of physician practices selling to hospitals, so that transfer of those business risks to hospitals. Well, now the hospitals have just had something probably historic with regard to operations that were significantly lower than what they had traditionally realized. There's a tremendous opportunity on the go forward basis with that. However, might we see, and I think it would be logical, as some of our clients have, quite frankly, had layoffs. They've looked at some contracts, reduced staffing, reduced requirements, with third-party staffing companies, transfer. I think it's logical to see that, base guarantees, for example, in the future probably will not be as high, where we had historically expected increases in rates? Perhaps not so much because of that risk and understanding where that value proposition actually falls out. It's going to take some time to flow through those. The biggest expense in healthcare, obviously, is our personnel. And so as we look at that, what is the right size? And again, going back to the modality of a telehealth or telemedicine type marketplace, what's the most effective use of that staff? Don Berwick, for example, in JAMA made the comment that he thought a significant portion of primary care visits in person weren't necessary, and that telemedicine allows for the appropriate use and time of a physician's in-person communication to be those that really need it. Might we see a fundamentally different primary care market, one that becomes more effective, looping back into kind of value-based care? So what stays and what goes? What's those benefit streams? We talked about value-based care in terms of how those pieces interact. So I think we've got a number of things to look forward to, but I think as we look at where numbers are going to fall out, whether it be in the pricing multiples applied, on the income approach in terms of discounts, and in the compensation in terms of the structure of the agreement, that we need to keep in mind in terms of that conversation about risk, understanding it. What do we think that risk is going to be going forward? And then the parties will negotiate. And it's really understanding it, comprehending it, communicating it, and then effectively taking that into account.
I think that sums it up really well. And honestly, there are so many different layers that we can go into on the overall topic, but specifically as it relates to the economic impact and even more specifically valuations. I think if we look at just some of the big picture statistics so far, I think a couple of things that we've researched and started to put out there is that, I think we can look at the uninsured portion of payer mixes is going to increase. The other thing I think is patients may not have the same ability to pay for elective procedures and other what we typically look at as high margin services. And that's going to affect, going back to the earlier example of a GI endoscopy center, things like that, where volume on higher margin services is already dropped, and it's not just going to come back overnight. So what is the long-term or even the near-term future impact going to be on that financially? Overall, healthcare spending has declined significantly, around 18% just in Q1. And we're expecting, significant continued declines in Q2 and trickling into Q3 as well. And then I think at the end of the day, you're going to find that many patients are just going to be slow to come back and hesitant to seek services in a traditional hospital setting. But, that's where we get back into what other opportunities may come up. What does this mean for the physician providers out there, physician practices that are considering their options? I think, the other thing we have to keep in mind is when you think about the economic factors, what are hospitals and thinking about whether it's a joint venture, whether it's a PSA, whether it's re-upping on employment arrangements or engaging in new employment deals, what will the selection process look like? Are they going to be more selective? And I think there's an argument to be made that, yes, they're going to have to be more selective. So I think there's a lot of this stuff that we've really started to dig into and think about. And again, we could probably have an hour conversation on every single one of these. Shameless plug here, mentioned that we've put out a white paper already looking at some of these things, and we'll have additional information coming out as well. Specifically, again, as Richard just teed up at a high level, some of the valuation considerations, but we can really get in the weeds on kind of some of the things we can expect to come out of that. As we think about kind of bring this full circle, wrapping up a little bit, I'll just maybe go around to each of you, and I'd love to just have your general, concluding thought on whether it's the next, as we record this, we're in June of 2020, and we think ahead to the second half of 2020 and beyond. what are some of your thoughts as far as if you're a hospital executive, if you are representing a group of physicians, or maybe even on the private equity side, what are some of the key takeaways or things to keep in mind based on where we are right now looking forward?
So I appreciated all of the information you just provided, Mark, and I'll just belie it with a couple more points. The study that I saw released a couple weeks ago said that as many as 1 in 5 primary care physician practices will not reopen after COVID. And that could be, physicians deciding to retire and take down their shingle. It may be individuals pursuing other opportunities. It may be the entire group taking a new track, like the PSAs Max discussed earlier. And I would say specialists aren't immune to this either, right? The Commonwealth Fund did some research and released their report May 19th. And the results show that the most impacted specialties were procedural and surgical specialties and pediatrics. The data that they have indicates that during the first week of April, so as this is just coming to a head, ophthalmology practices were reporting a 75% change, of course, a decline in patient visits over the baseline. Likewise, otolaryngology and dermatology visits were more than 70% off of their baselines. Those with the smallest impact were reported to be behavioral health and adult primary care, but even those had double-digit impacts. And so I think that there are going to be deals that need to be made, and some are truly out of need. Physicians, are unable to weather the storm that is in front of them or that they're passing through right now. And some are going to be hospitals making strategic decisions about where they want to put their dollars going forward. And I would just give some advice here to people that are responsible for deals. I think you need to differentiate between your mentality, how you approach your transactions. And that is, number one, do you focus on what we want? The march up the hill mentality. So this is what we want. We want this practice. And so many acquisitions, I think, rightly or wrongly, begin with this mindset. We need X deal to happen to be able to achieve Y. And so it feels, from a deal-making perspective, that there's a commodity to be acquired. And I think when we stop and we think about the fact that these aren't commodities, these are people that are providing services with scads of employees that are supporting them. I think we need to think about, should our mentality instead to transactional work be, this is who we are. You can help us best serve our community, our patients, do what's right. And so during times of crisis like this and immediately after, I think this is the more preferable approach to affiliations, alignment, transactional work. Enlist what would otherwise have been thought of as targets instead as partners in these discussions. And so really focus on who we are and what these people can help us achieve in terms of that vision of self, with them as partners in it, as opposed to taking them on as to, what we want or what commodity they represent. So I would just give that 2 cents worth of advice to people as they think about where we are.
Great points. Max or Richard?
Yeah, I'll go ahead. And Richard, you can wind it up. I agree that this is an unprecedented situation. And so it's hard to look into any crystal ball. I am the oldest of our group here. And the only advantage I have is simply that I've been doing it longer than everyone else. But I don't really have any great insights better than my colleagues. But I will say this, I do think that we're resilient as Americans, and I think our healthcare system will rebound and will be resilient. I'm optimistic. I think we have to, just as I think back on a couple of other notable events, if you want to mark them in time, at 9/11 and even when we kind of first, as a healthcare industry, started to get into the 21st century on technology, there was a lot of questions and concerns about how that was going to happen. And post 9/11 was anything our lives going to ever be the same. And granted, they're not the same. And I don't think that the pandemic that we've been through and still going through will be any different. I don't think we'll be exactly the same as we were, but I do think that we're resilient. We can work within our system. It can be successful. One of the examples that I think will be a major change, we've already talked about it a couple times today, is the fact that significant amount of our healthcare delivery will be different in the package that it's delivered, such as telemedicine. I personally think that somewhere in the neighborhood of a third of all care, and that's a big universe when you put all care into that universe that I'm referring to, but at least a third of that will be more within some form or fashion of remote care, telemedicine, etc. And so is that a change? Well, you bet it is, because we've been talking telemedicine as a consulting firm for years and years, and frankly have had relatively little response up until now. And overnight, literally, it took this pandemic to change the paradigm. And there's not a whole heck of a lot of good that I can see that's come from COVID-19. But if you do want to look at any silver linings, that's probably one of them, where at least we've kind of all come around to realize that the technology will work and we can render care in that manner. Well, that's a difference. That's a change. And we can debate whether that's good or bad, I suppose. But what I'm trying to say is we're resilient. We're looking at other ways to provide care, to be more efficient. I think one of those ways will be to continue to align and aggregate, consolidate, all the things we talked about. Economics will continue to be important. I always say to any hospital, for-profit, not-for-profit, you don't have to apologize for having a black bottom line, because that gives you the ability to carry out your mission. And that's a good thing and needed, obviously. So I think economics will continue to be important. We'll need to manage our costs better. We'll be smarter in terms of how we do that. And again, if there are any silver linings, I think that's where they'll come from. So Richard, wind it up for us. Tell us, give us that silver bullet.
You know, Max, I'll try and had a couple of thoughts. One that just came to mind is thinking about the major changes for the old timers that are listening to this. Just as a little comedy at the end, I just wonder the folks that used to do the calculations for the sustainable growth rate formula that we used to live and die with. I wonder how glad they are that we're no longer under that kind of scenario. I think, you know, the big takeaways in my mind will be really kind of the watchword that Aimee really said is what stays and what goes. And as we look at this, even as we deal with and come back, that there may be some pent up demand associated with some of these services that were delayed. Some degree will come back. What's that level? The addition of telemedicine, how is that going to impact the practice or the service lines? And I think it is really looking at this as a strategic opportunity to decide what you want to be and how you want to go about it while you're looking within your service market. But I think the biggest way that I would say it is, given the virtual nature of care, that has gone from a game of chess to perhaps 3D chess, and you're looking at things on a different dimension. And so it's going to be incumbent upon leadership, just as we talked about dealing with a pandemic and a challenge, overcoming that, coming out of it, but also taking advantage of it going forward and looking at the best use of what could be limited capital coming out of that to have sustained long-term operations and quite frankly, the purpose of your organization.
I think that sums it up well, all of you. You know, again, there are so many different factors to this topic, this conversation, and we're just kind of grazing the surface on the different variables and elements to it. And again, shameless plug. I'll plug our white paper that we recently released on this that covers a lot of things we've talked about, but goes into more depth as well. We'll make sure that is available as a link in the show notes of this episode. But also, I really encourage everyone to stay tuned and to watch some of our information coming out, because we are going to continue this conversation. This is something that, like telehealth, as we've done the past couple months, we are going to watch and continue to monitor going forward into the future, because this is not just going to be one of those things that pops up and goes away. This is definitely going to be something that there are all these different pieces that we've just touched on relatively briefly today. We're going to have to go into more depth and really kind of get into the weeds on them further, as far as understanding the impact and the different audiences involved, and what it means for, physicians out there and their practices, what it means for hospitals, what it means for investors and private equity and everybody else. Obviously, there's an impact on the patients as well. So there are so many different ways this is relevant and meaningful for all of us. So I look forward to those future conversations. I really appreciate you all contributing today. And there will be more to come on this. So I just, again, encourage all of our listeners to stay tuned and look forward to continuing the conversation going forward. But in the meantime, thank you all.
Thanks, Mark. Appreciate it.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.